It is important for us to be able to differentiate and know the function of each of the medications. Most of the medication for COPD and asthmatic patients are inhaler form. Basically, we can divide the asthma and COPD medication into two, which are reliever medication and controller medication. Reliever medication is used during acute attack, while controller is to prevent any acute exacerbation of asthma and COPD. Adrenergic and anticholinergic are the main bronchodilator for asthma and COPD attack. It is only consumed when needed, which during exacerbation. A bronchodilator is a substance that dilates the bronchi and bronchioles, decreasing the resistance in the respiratory airway and increasing the airflow to the lungs. Bronchodilators may be endogenous, which is originating naturally within the body, or they may be medication administered for the treatment of breathing difficulties. They are most useful in obstructive lung diseases, which asthma and chronic obstructive pulmonary diseases are the most common conditions. SABA or short-acting bronchodilator and SAAC or short-acting anticholinergic are the main common reliever being prescribed by the physician, and salbutamol is the main reliever drugs. Long-acting bronchodilators such as formoterol, salmeterol, usually taken together with the inhaled corticosteroid in asthmatic patients. Do you able to remember back the corticosteroid that you have learned in previous semester? Inhaled corticosteroids, or ICS, are used as anti-inflammatory and controller, as well as maintenance to prevent any acute asthma and COPD attacks. Two classes of monoclonal antibodies, which are anti-IgE and anti-interleukin 5, are currently licensed for poorly controlled asthma despite optimal use of the medical therapy. Omalizumab is commonly used in Malaysia, and it is a recombinant humanized monoclonal anti-IgE antibody that inhibits the binding of IgE to high affinity receptors. Thus, it will reduce the inflammatory response. Meanwhile, mepolizumab, which is an interleukin 5 antagonist monoclonal antibody. Both of these drugs act as an add-on maintenance therapy in moderate to severe asthma, which uncontrolled with moderate to high dose of ICF with or without the LABA. Theophylline and montelukast are the non-steroidal anti-inflammatory that usually be prescribed together with inhaled corticosteroid for uncontrolled asthma patients. Roflumilast, which the only PDE4 inhibitors that available in the market, is being prescribed to the uncontrolled COPD patients only. Before we go further on the medications, we need to classify our patient into stable and acute exacerbations. Different patients have their own treatment regime based on their health status, disease severity, symptoms, and frequency of exacerbation. A patient is said to have stable asthma when there are absence of symptoms, no limitation of activities, and no use of reliever medication in the last 4 weeks. Alternatively, stable asthma is classified when the ACT scores are 20 to 25. Medication reconciliation can reduce medication errors and support safe use. Pharmacists make interprofessional efforts to establish and maintain an effective medication reconciliation process in hospitals and across the health systems. Involvement of pharmacists is key in preventing the adverse drug event, as well as developing the patient-centered approach to enhance their participation. Our role here may encompass discontinuing unnecessary medications, switching to less expensive or more effective medications, or altering the drug administration route. Patients with initial presentation of the following conditions are considered to be managed in Step 1. Patient that has asthma symptoms or need for salbutamol that less than twice a month and no wake up at night due to asthma in last month, and no risk factor for exacerbations, including no exacerbation in the last year, this kind of patients, we only prescribe him with salbutamol and take when needed or during acute attack. Controller is not required unless this patient has risk of exacerbations. We can advise physicians to initiate low-dose ICS such as beclomethasone, fluticasone, and budesonide. For the patients who remain symptomatic in step 1 are required to escalate to step 2. Patients with initial presentation of the following conditions are considered to be managed in step 2, which are asthma symptoms or need the salbutamol in twice a week or up to twice a month, or wake up at night due to asthma conditions once or more in a month, and no risk for exacerbations. These patients need to take low dose of inhaled corticosteroids such as 1 to 2 puffs twice daily of beclomethasone, fluticasone or budesonide. 1 tablet daily of montelukast or theophylline are another options for controllers. This type of patient also will be prescribed salbutamol as a reliever therapy during the acute attack. Patient in step 2 that remains symptomatic should be escalated to step 3, and the new patient who experience troublesome asthma symptoms more than twice in a week or wake up at night due to asthma once a week or more, and with risk factors for exacerbation, they should change their reliever medication from salbutamol to a combination of inhaled corticosteroid and long-acting beta-agonists such as Symbicort, budesonide formoterol, and Foster, which is beclomethasone and formoterol. These two drugs act as a preferred controller and reliever. Patient in step 3 that remains symptomatic should be escalated to step 4, and the new patient who experiences troublesome asthma symptoms more than twice in a week or wakes up at night due to asthma once a week or more, and with risk factor for exacerbation that requiring hospital admission, their reliever medication should be a combination of inhaled corticosteroid and long-acting beta-agonists such as Symbicort and Foster. This drug acts as preferred controller and reliever. Besides that, Spiriva Respimat, which is tiotropium, can be added on to dilate the bronchiole in the long-term effects. Patients who are in step 4 with persistent symptom and exacerbation despite good adherence to medication and good inhaler technique should be referred to respiratory physician for further evaluation and treatment. To manage the acute asthma exacerbation, high-dose inhaled salbutamol up to 10 puffs in every 20 minutes for the first hour is effective for all patients. For severe and life-threatening asthma, the salbutamol will be delivered through nebulizer. In the managing stable chronic obstructive pulmonary disorder or COPD, bronchodilators remain the mainstay of pharmacological therapy. They reduce airway smooth muscle tone, improve expiratory flow rate, reduce air trapping, and hyperinflation of the lung. They also improve the patient dyspnea scores, increase exercise tolerance, reduce disability in daily living, and improve overall health status. The optimal pharmacotherapy should be guided by this patient's symptoms, level of activity, and frequency of COPD exacerbation. For infrequent symptoms of mild COPD patients, SABA such as salbutamol or terbutaline can be introduced to them. Ipratropium bromide or atropine can be introduced to the moderate up to very severe COPD patients. If the symptom persists, long-acting bronchodilators inhaler such as salmeterol, formoterol, or tiotropium can be introduced to them. This is the algorithm for managing acute exacerbation of COPD. It's not much different compared to the managing acute exacerbation of asthma. These patients need to inhale short-acting bronchodilator such as salbutamol via spacer device or nebulizer depending on the severity. If the patient fails to improve, quickly to admit them to the hospital for further assessment or admissions.